Chair Anjali and Sarah coming in for this clear study. And so they're going to talk a little bit more about potentially becoming more aware of hypoglycemia for those that are just a little bit less sensitive to it. So thank you for your time, and I'll hand it over there to
Awesome.
Anjali.
Well, I'm Anjali Kumar. I'm a PA at the University of Minnesota in endocrine, adult endocrine. And Sarah Zahn is a very experienced diabetes educator too. You want to say hi, Sarah? Uh,
Hello, everyone. I used to work with Brad at Alina too.
Yeah. So Sarah and I are here today because we just kind of wanted to learn a little bit more from your community and also just tell you a little bit more about what we're doing and opportunities that you may know somebody or be interested in learning a little bit more about hypoglycemia unawareness. So maybe just before I get going, show of hands, does anybody know anybody affected by what we call impaired awareness of hypoglycemia? Okay. Or know anyone who's had pretty severe hypoglycemia where they've kind of been confused, unable to treat themselves, that sort of thing. Yeah. Un Unfortunately, it's fortunately it's pretty rare. I hope it's pretty rare and people recover, but it's kind of a problem that sometimes we don't think about as much, especially maybe as I study hypoglycemia, so that's kind of it's something that I think about all the time, but I think sometimes out in the general primary care or others, hypoglycemia isn't discussed as much as I think it should be. So, so just here to kind of bring a little bit of awareness there. So I'm going to go ahead and share my screen. I would love for this to be interactive. If anybody wants to like chime in or has any questions, just please feel free to interrupt me at any point. And I'm replacing the current share. So let's see. Okay, and then let's just do this. All right, can you see my screen okay? So I'm part of a larger group. Oh, and I see Ellen's on. I know Ellen. Good to see you. I'm part of a larger group here at the University of Minnesota. I work with Dr. Betsy Sequist, who's the principal investigator, and Allison Alviar, Lisa Chow, Lucia, Amir, Shannon, and Sarah are all part of the team that's part of the CLEAR study. The CLEAR stands for Closed Loop and Education for Hypoglycemia Awareness Restoration. So trying to restore symptoms of hypoglycemia. It's sponsored by the National Institutes of Health. So basically I'm going to outline today kind of a little bit of an introduction to impaired awareness of hypoglycemia. I'm sure many of you don't need an introduction to that, but that's something I'll do. A brief overview of the study, maybe some benefits to you if you were interested in participating, and some logistics and next steps if that's something you wanted to pursue a bit further. All right, so impaired awareness of hypoglycemia increases the risk of severe hypoglycemia sixfold in people living with type 1 diabetes. And we know this risk remains persistent even though so many people use CGMs and hybrid closed loops. We were hoping that would be sort of the fix and this would be a problem of the past. However, it really does not entirely eliminate the risk of severe hypoglycemia. We know that shorter studies show that hybrid closed loop restores awareness in some people with impaired awareness of hypoglycemia, but not everybody. In the UK particularly, there's been some psychoeducational courses. So courses developed in combination with psychologists and diabetes educators, endocrinologists, that have been proven to be effective in restoring awareness of hypoglycemia. However, unfortunately, we do not have this as something that we can do in the US. We don't have a reimbursement for it or a way of delivering it. So in this study, this is going to be offered as part of one of the arms of the study as well. And I'll go into it a little bit more. So my Hypocompass is a brief standardized, sorry, I spelled that wrong, psychoeducation program. It focuses on rigorous avoidance of hypoglycemia and talking about like the prompt treatment. Because how many of you have like been like, oh yeah, I think I'm going low, but I'll take care of that. I just have to finish this or whatever I'm doing. So it's sort of like retraining you to kind of pay attention to those earlier subtle signs that may be happening. And then also just being aware of high risk situations that, we all know, but it's easy to forget as you're going about life and just trying to live a life without diabetes interfering so much. It's a course that's delivered in small groups. It's delivered by a diabetes educator, and it is a significant time commitment. It's 5.5 hours over 3 sessions. And I'll go through like the structure of the entire study coming up soon. Um, Hold on 1 second. I feel like I may have missed a couple slides. Hold on, because I feel like, just give me 1 second. I may have jumped a little bit. No, I think I'm okay. So with the knowledge that we may have access to some psychoeducational courses that could be effective, we want to know, yeah, somebody have a question? No? Okay. Um, so because, hybrid closed loop is around, could hybrid closed loop for a longer period of time lead to improved restoration of awareness? So people come into this study either having been on hybrid closed loop or not having been on hybrid closed loop. And if they're not on hybrid closed loop, they could be offered hybrid closed loop. And if they're already on it, then we give them maybe a little bit longer period of time to improve awareness. And we also want to know, are psychoeducational interventions more effective at restoring awareness than hybrid closed loop on its own? And we want to know, can we actually identify groups of people with certain characteristics which respond better to one treatment over another? So the CLEAR study, it's a unique opportunity. It's really the largest ever study into the treatments of impaired awareness of hypoglycemia. And like I said, it's a 2-year randomized clinical trial. It's a worldwide study, which is very exciting. Sarah and I have been in the whole development process for the last year or two, and we've got 5 sites in the US, 1 in Australia, 2 in the UK, and really it's the world's experts in hypoglycemia that are on this committee and that have designed this study. So we're looking at 45 participants here at the University of Minnesota, but 324 worldwide. And we're, trying to find out if new technologies and educational courses can restore awareness. And the control arm of it is standard of care. So like what you're doing already versus adding a hybrid closed loop or education. And we measure the restored awareness by causing you to be low experimentally once a year for 3 years. So we do it at the baseline, 1 year into it, and then at the 2-year mark. And we bring you into a clinical research center and actually give you insulin, lower your blood sugar in a very controlled way, and then kind of keep you at different levels. And then we measure how you respond with your hormones and your symptoms to kind of see how well you sense your hypoglycemia. We're also doing some cognitive testing, like to see, just sort of some tasks that you have to perform and see, you're comparing yourself when your blood sugar is normal to when it's low. And then we can kind of see, does that change over time as well? So this is a complicated slide. You don't need to know that much about it, but just knowing it's what's called a SMART design, where we have 2 randomizations. So we either, you come into it having been on hybrid closed loop pump over here on the right, or if you've never been on it, you would either get it or continue your usual care. And then at 1 year, if you haven't restored awareness, then if you were on usual care, you would get a hybrid closed loop pump. And we provide those pumps to people in the study if they were never on a pump. If you are already on a pump, then we would just keep you on the pump you're on. And likewise, if you were on a hybrid closed loop pump and you didn't restore awareness, then we would either do more hybrid closed loop or add the education piece of it as well. So anyway, we could get more into the details on that, but basically we're going to make sure that we're treating you appropriately and we're going to intervene if it's not working with another education. Patient study visits, there's actually 19 visits over 2 years. So it is a big time commitment. 13 of them can be virtual, done by video or phone. Sarah's going to be the primary person doing that. And those are visits where we basically kind of look at your pump downloads, make recommendations for pump adjustments, basically like what you do in your endocrine clinic. However, we're going to be taking over the pump management or injection management and communicating with your primary endocrinologist. You would still see your primary endocrinologist on your usual visits, but we would just send them a letter asking them not to make changes to your pump settings and things like that. So it also includes 3 clamp studies, and I'll explain what that is. That's when we lower your blood sugar or adjust your glucose in a controlled way. And then the education components are listed here as far as how much time is involved. We are flexible as far as how when we do the appointments and things like that, and doing them virtually can help as well. And then we also ask you to wear activity monitors, track your hypoglycemia and symptoms with an app, and do some questionnaires. So it is a pretty involved study, but we do reimburse you for your time and effort that way as well. Like I said, it's an intensive study requiring a lot of time commitment. This is what is a clamp study. We give a fixed rate of insulin we vary the amount of glucose to achieve like different levels of glucose. And we would either have you at 95, 60, or 47. So, and we keep you there for a certain amount of time so we can do some of the cognitive testing. You're kind of in a hospital bed and there's a nurse, a doctor, where they're watching things very carefully, monitoring glucose every 5 minutes during the study. So it's a very safe environment. And if for some reason we can't get your glucose because your IV is not working right, then we stop the study and raise your glucose. And during this time, we're asking you about symptoms that you may or may not be having with hypoglycemia. And then we're also assessing your cognitive function along the way. So I know this is a lot. Any questions so far? Yeah, Brad.
Just wondering, when you're doing that clamp, do you cut off the CGM too, or it's no MRI,
We
right?
just there's no MRI. We just disable the Bluetooth for the period that you're doing the clamp because we don't want you to know where your blood sugar is.
Yep.
And so we just turn off notifications and disable Bluetooth, and then you resume that right after.
Okay.
Yeah.
Cool.
Likewise with your pump, if you're on a pump, you would just disconnect the pump. With the Omnipod, you would have to remove the pump because I think it just actually beeps. Is that right, Sarah? Would you actually have to remove it? Yeah. I don't know if it can like be silenced when you're doing that, but yeah, generally speaking, you just hook back up as soon as we're done.
Okay. But Omnipod, you could just suspend it, right?
Someone, Omnipod told me that it still has the actual pod can beep when you're below, um, must be four,
I
I
think
don't know if it's 60 maybe.
I think it's 54, isn't it?
Yeah,
Less than
54. And I think
54?
the pod actually will beep on its own. That's what they said. So they suggested just removing it.
Can anybody speak to that? Because that's new news to me. I never knew that the pod actually beeped. I think it would just be your app or something like that.
That's what I thought as
I
well, but when
know.
we were going through this, they made it very clear that like we would give you a replacement pod if you were on Omnipod, but then you worry about like wasting the insulin and things like that too,
Yeah.
you know.
I
So
mean,
that
not too much of an inconvenience, but I've never been aware that you could do anything CGM wise from the Omnipod that it would actually pick up any glucose. So usually it just has that expiration. But
Yeah, I
anyways,
don't know if it was. Yeah,
Have to
we
double
should
check.
double check that,
Yeah,
but when we were looking into it, that's what they had said.
Yeah, I'm
yeah.
sure you can query some patients. Hey, we got a bunch of people on Omnipod 5 too, but I think it's always just been Dexcom alerts.
It's,
But
it's never
anyways,
been.
sorry.
Yeah, no problem. So yeah, Carol, you have a question?
Yeah, I used to be your patient,
Oh yeah, good to see you.
and now I'm Dr. Sequist's patient again.
Yes.
So I
Great.
do. She never told me she was doing this study, but so we've discussed my hypoglycemia unawareness. However, I have never, in 21 years, had to have somebody else help me do anything.
That's
So does
fantastic.
that? I think I got from reading the description of her study
Yeah.
that wouldn't qualify as hypoglycemia unawareness.
Oh no, it absolutely is because we don't, I mean, I'm so glad that you've never had that experience before. But what we want to do is keep your symptoms sharp and alert you, right? We don't want your first symptom to be confusion. And often it is, where, you're just not processing right or not functioning quite right. You can still kind of treat yourself, but it's kind of getting to that later stage. So no, that would not disqualify you in any way.
Because I
People,
really I rely on my Dexcom
yeah,
totally
yeah,
since I don't have symptoms.
exactly.
But all I have to do is look at it and then I know what my number is.
Yeah, we have like a standardized questionnaire that we would go through with you just to determine like how well you sense your hypoglycemia. And that's generally the qualification. I think you self-identifying that I don't feel my lows and I would like to start to feel my lows. That's where it's interesting. Some other people I've talked to who've had this problem, they're kind of like, well, I don't know what you're going to do for me. I don't feel my lows. I'm never going to feel my lows. And I think that's where the challenge is we actually do have data to say we can help you restore your lows. And that's kind of something I haven't really been able to offer patients in the past, right?
Okay.
um, apart from, hopefully avoiding low blood sugars and then with the hybrid closed loop pumps, for instance, and then minimizing the exposure, which we hope will help restore some of those symptoms. But it's a tough issue. But yeah, but no, that would not disqualify you. So
Okay.
the who can participate as long as you're 18 to 75, you've
Oh,
had,
and I'm too old. I'm 82.
oh, well, we got you on something there. um, duration of diabetes over 10 years. And if you suspect you may have impaired awareness of hypoglycemia, or if you've had a severe episode of hypoglycemia, reach out to us if you're interested. And just A1C has to be less than 10.5. Because of the education materials, unfortunately, we can only have English speakers and readers at this time. I would love to expand that, but that's where we are right now.
Come on, Sarah, get multilingual.
Yeah, exactly. We got to move her along. And then exclusion is, if you're pregnant or kidney disease with, and we could go through the details if anybody's interested. Um, and then, like I said, it's a 2-year study, potential benefits to you. If you haven't had hybrid closed loop, that's something we would give you. We have unique access to psychoeducational courses, and hopefully reduce some diabetes distress. If anybody has questions, I'm happy to take any further questions. Otherwise, I just really appreciate you taking the time to have us on. Yeah, Brad.
I suppose you just personalize it based on the patient, right? Do you guys have a set, like you put someone on Omnipod, they're naive. Do you guys pick a target of 130, 120,
We
140?
we talk to the patient and see what their preferences are. Sometimes we'll
Gotcha.
start at a higher target and just work with them and see, some people want to be at 110 and that's where they want to be, and we work with that. But the primary goal is to avoid hypoglycemia while trying to keep that time in range pretty decent. But generally speaking, it's kind of like clinical practice, but Anybody who's participated in a clinical trial before, though, will probably speak to the fact that you just get a lot more contact with your care team. And there's just not as many time restraints as you have your 30-minute appointment in the clinic. So that way it can be a little bit different and more frequent contact because we're seeing people every month for the first month and then every 3 months after that. So yeah, Ellen.
Turn on my audio. Can you hear me now?
Yeah.
Okay. Since Betsy first mentioned this, at least to me, I have aged out of your group.
Oh,
However,
yeah.
I looked at the applicant form online because again, I had heard her speak of it theoretically, and I
Yeah.
wanted to know what all you were looking for. It looked as though the goal, maybe I misunderstood this, but as though the goal were to be able to recognize hypoglycemia at least at the level of 60, blood glucose reading of 60.
Yeah.
Now, if that is correct, this is sort of a testimonial, but also a comment on your study. For the last 10 years, I have worked with Betsy and Anjali, uh, and I've always tried to be very careful, but I grew up long before CGMs were available. I've had one of those for over 20 years now. Anyway, in the last 10 years, I have recovered just by trying to control well, to manage my blood glucose.
Yeah.
I have gotten it to the point where I now feel symptoms at about 60, blood glucose level of 60.
Yeah.
So theoretically, I have managed to do what your study is questioning whether everybody could do.
Yeah.
Is that correct?
Which is fantastic. I mean, we know that even 2 to 3 weeks of strictly avoiding hypoglycemia can restore some of those symptoms that we get, like heart racing, feeling like your heart's pounding, shakiness, tremor, those sort of symptoms.
Having waking up as the EMTs inject glucose.
Yeah, that's not fun.
No, it is not, but that was
No.
before I had a CGM.
Yeah. And being aware of where things are. I mean, CGMs have, I think that's the number one piece of technology that people with diabetes, can have. But you're absolutely right. Strict avoidance of hypoglycemia can restore those symptoms and bring them to a higher level, which I think is really great. In practice, it's sometimes difficult to do, especially when you add in physical activity, busy lifestyle, so many stresses. I mean, you all know what all goes into managing it. It's a lot, even with the greatest technology. But that's great, Ellen. I'm so glad that you've been able to kind of reverse it. But it's taken you a lot of work, I think, to get there.
And I don't depend on it truly
Yeah,
because it is not 100% of the time.
yeah,
If I'm busy thinking about other things and for a moment am not thinking about T1D,
yeah,
forget it. I can easily fall below that and
yeah,
eventually feel it, but by that time I certainly shouldn't be driving or doing other things that require brain power.
yeah, absolutely.
I have a question.
Yeah.
I think you said you were going to go over the clamp part of
Oh,
the
yep,
test
yep.
or the research study. So maybe you could just talk a little bit about that.
Yeah, so clamp was this part where basically I didn't want to give everybody too many details if it was, overwhelming. But basically, you would come into the University of Minnesota Clinical Research Center in the morning, 7 a.m. We would put an IV in each arm because we're going to give you insulin, glucose, and a little bit of potassium. Anytime we give IV insulin, we also give a little potassium. just because it can cause insulin to shift into the cells. Or potassium to shift into the cells. So we just want to make sure that you're getting a steady amount of insulin. And then we kind of make sure your blood sugar is right around 95 before we start the study. The study itself is about a 3-hour procedure where we adjust your glucose to different levels. And we don't want you to know the glucose level because we're going to be asking you about how you feel. And if we tell you, oh, your blood sugar is 50, you may, expect to feel a certain way. So you're kind of blinded to the glucose. Every 5 minutes, the nurse will draw your blood and then put it in the glucose analyzer. And then our medical assistant will give us an accurate glucose, so that then what I do is I adjust how much glucose I'm giving you in the IV to keep your blood sugar at one of these levels. It's either at 95, 60, or 47. And then during those steps, we ask you a whole lot of questions about how you're feeling. We are having an EKG monitor on you the whole time for safety and just making sure you're not having heart rhythm problems. And then we do some cognitive testing. So you think of it as just kind of laying in a bed, you're watching TV, something light, Travel Channel or cooking show or something like that. And then you're not going to probably feel the best if we're lowering your glucose. However, if you don't really feel your low glucose, then maybe it won't bother you as much. But it is kind of an involved experiment where we keep you at different levels. But really, safety is our number one priority. And if you're at all uncomfortable or you don't want to continue, we would stop it at any point. But I've been at the University of Minnesota since I graduated. So I've been working here 23 years and been doing variations of this clamp procedure the entire time I've been there. So we've been doing like different questions to do with hypoglycemia. And so this is kind of the gold standard of measuring your hormonal response. And what we're measuring is actually epinephrine. So they're hormones that are kind of your body makes to alert you to low blood sugar. So epinephrine, norepinephrine, those are kind of your fight or flight response hormones. And then we measure something called cortisol, which is a stress response hormone, growth hormone, which is another stress response hormone. And so we can then see, before you had the intervention, how well were you responding, or how did you feel your lows? And then at the end of the intervention, we do it again. So we do this clamp study once a year. The whole process is about, I'd say, 5 to 7 hours, because we have to make sure your blood sugar is stable before you come in and then before you leave and all that sort of thing. So it is a pretty involved day. The other visits are a lot shorter. So does that answer your question about the clamp study or what we'd be doing in that?
It does. Yeah, I guess it just makes me a little nervous. What if a person goes, I'm sure it's all very controlled, but
Well, it's strange when somebody else is managing your glucose and they're dropping you low. I mean, it's a weird feeling because you're used to being in control of that. And understandably, it's not for everybody. Not everybody wants to do this. But just for reassurance, we check your glucose every 5 minutes. We've got very experienced people doing it. And we're not going to let your glucose get too low because we have glucose going right into your IV. So if your glucose starts to get a little bit low, we just give you more glucose.
Okay.
Yeah.
That's helpful. Thank you.
Yeah, I know. It's kind of a strange procedure, but it's very common in the diabetes world.
Okay. Thank you.
Yeah. Anyone else? Anybody interested in sharing their stories about hypoglycemia, or anybody have any thoughts?
There's another hand up, Anjali.
Oh, yeah, sorry, I can't see everybody.
I think Troy.
All right.
Just two quick questions.
Yeah.
How do you measure the hormones, and how do you get your blood glucose level down to 47?
Oh, Well, we give you a weight-based, I'll answer the second one first. We give you a weight-based amount of insulin in an IV. Now, IV insulin is a very quick insulin. And so when you take an injection of insulin, that can last up to 4 hours. When you give IV insulin, it only lasts about 45 minutes. And so we give you a steady amount of insulin, and then so it's enough to bring your blood sugar down. And then we also give you glucose in your IV. So it's a very well-oiled machine how we do this, but we start off giving you insulin with glucose. And then when we want to drop your glucose, we just withdraw some glucose, allow it to fall, and then give you more glucose to hold you steady where we need to go.
Gotcha.
Does that answer your second question?
It does, yeah.
Okay. First question. Now I'm trying to remember what it was.
The hormones.
The hormones, yes. So we have a specialty lab at the University of Pennsylvania where we send our hormones out. It's a core laboratory. It's just a blood test. And all these hormones are in the blood pretty immediately when you have hypoglycemia. But we're measuring them about every 30 minutes through the study so we can see at different levels where your hormones are. So it's really informative. And then when you couple that with your symptoms, then we can kind of say, okay, you're having a pretty robust response to hypoglycemia. You're having symptoms and your hormones are elevated.
So you send the blood out then?
Yeah, we do. Yeah, they're send out labs. They're kind of specialty labs. They don't just run them in the hospital. So we've got a research partnership with the University of Pennsylvania. So they're going to be analyzing all of ours. Good question. But yeah, we don't measure them clinically typically because it's such a, who goes to the lab when their, blood sugar's low? Quick, let me see my epinephrine level. Can't get there at the right time.
And a half a cup of the
Yeah.
beans. How many? 30.
What?
Sorry about that. Someone was asking about the recipe, so I just muted that.
Oh, recipe sounds good. Anyone else? Carol, did you have another question?
Yeah. I mean, I've had a Dexcom now going back to the G7. Wasn't that the first one?
Yeah. G4 or
no, before the G4 there was the 7 Plus. It was called the 7 Plus.
Yeah.
So anyway, the current one is so fantastic. I use the G7 now and I love it. But I mean, I set my alarm, I think it's 70 or even 75, and it alarms. So, I mean, if somebody has a Dexcom, I mean, a CGM, how can they not know what their blood sugar is if they set the alarm?
Well,
I mean, even if you don't have any symptoms, it tells you you're too low.
Well, I don't know if has anybody ever had the experience of not hearing it and maybe a partner or somebody else telling them.
Well, the reason I don't hear it, Carol, is that I do not have the alarm on. Now, it's still, the pump itself has an automatic alarm that will not go off. My tandem pump and Dexcom G7 has a pump that sound that I cannot turn off, but I think that's, I don't know, 50 or something below 60. When I first got my pump and it started beeping this and that, at the very lowest level of sound, people at church complained. And I thought, oh, well, I don't want to quit going to church in person. So I just turned it off.
See, I don't have a pump. I just have a Dexcom. Yeah. And I always hear it.
Well, that's good if your friends and your colleagues and the associations you are part of do not find it annoying. But to me, going to church was important enough that I thought, fine, I can manage this. I can pull it out of my pocket and look, which I do. But again, the pump is not 100% accurate. So if I'm concerned about it, I take a test.
I guess the other thing too is everybody's different. Some people don't look at their CGM every 2 seconds.
Yeah.
So if you look at it constantly, you know what your blood sugar, well, it's not really your blood sugar, but your interstitial fluid glucose. Anyway, I just think it's the greatest invention since white bread.
Well, I mean, especially having navigated life so long, probably without it, it just now seems like you can't fathom being without it.
Right.
It's changed.
Absolutely.
However, I think you raised a really good point, Carol, because I think there's a difference between feeling it and knowing, right? Like you can know your glucose by looking at your sensor or getting an alarm, but what we're really getting at is we want you to actually feel it.
I realize that, yeah.
Because we know technology can fail, pumps can fail, things can happen. And really, like that ability to sense it yourself, I think is really important. I know amongst athletes and it's just a real big problem because, it's exercise itself can blunt your awareness of hypoglycemia. Sleep can blunt your awareness of hypoglycemia, things like that. So any way we can restore actually the symptoms, even though people don't feel great when they feel it, but it's good to actually know. Any other thoughts? Yeah, Brad.
Sorry. So curious because it says Omnipod 5, it says Medtronic 780. Is your site only doing Omnipod 5 for what you guys are offering patients? Are you guys going to be comparing different pumps? Because obviously I think Omnipod's probably the most reserved, then Medtronic, and then you got Tandem. We got a lot of tandems in this support group here too.
Yeah. So what we're doing is we're taking all comers. So we unfortunately only got funding from Omnipod to give pumps out, right? So the other companies we don't have any contracts with. So it's probably a small slice of the population that's actually going to get a pump from us because most people either are already on them because this is a big problem, right? And most people have tried hybrid closed loop, or they've been resistant for a long time for other reasons and maybe didn't want a pump. So if they come into the study and they have to be okay with going on a pump if they're not on one. And we can provide an Omnipod, but if they choose to get a different pump, they would just get it through their insurance company, and then we would continue to support them with whichever pump they choose.
So Libre users wouldn't be eligible, correct? They'd have to switch.
No, they can use Libres if that's the one they choose. We just need standardized Dexcom G7 data for 1 month before each clamp study. So we would give everybody a Dexcom G7 blinded sensor to wear for 1 month before, so that everybody's data looks the same. I know it's kind of a strange setup, but basically all comers, all pumps we would welcome, but we can only supply Omnipods because that's who funded us, or that's who donated pumps.
Yeah, and I hope the studies go well, the sensors work well, but I know every once in a while you get a dead sensor, so that'll be interesting how you guys
Yeah.
eliminate those outliers or be like, hey, this is odd.
Yeah, I know. And, I mean, some people love the G7, some people love the Libre 2 Pluses, the G6s, but you can use whichever sensor you want in the study. We just have to have a month's worth of data.
But don't they have to be on a hybrid closed loop though in the study?
Yeah, but they can use whatever is working with their hybrid
Their
closed
pump.
loop. So if they
Okay.
come in on a Libre 2, they could just stay on that. But unfortunately, we don't provide that, but we would just help them manage that.
Gotcha. Thank you for clarifying.
Yeah, sorry for the confusion. Michael, did you have a question?
Yes. Let me drop my hand. Lower hand. I qualify for the most part, and
Yeah,
I'm willing to do the study.
yeah.
I live in Mason City, Iowa,
hmm
and I think that we should discuss the probabilities of me becoming a member of the study after this meeting is over,
Sure.
or
Yeah, we
send
can
an application, or
yeah.
whatever.
So I appreciate your willingness to talk to us, but basically we do have the funds to be able to support like a hotel stay when you come, and then your gas and things like that. So we do have reimbursement for that if you choose to come. a lot of them, like I said, could be done virtually, and we can kind of combine some visits together, like a screening visit and the visit before the clamp study. What I would recommend is, I don't know if you can, well, maybe I can have Brad send it out afterwards, but you could either scan this QR code and that would direct you to a link where you can take a little survey with very basic eligibility on it. That would give us your contact information and give us permission to reach out to you. And then
Okay.
what we do is we'll set up a pre-screening visit where Sarah
Sure.
would give you a call and then go through more detailed inclusion and exclusion qualifications. And that, because we don't want to bring you all the way from Iowa if you're not going to qualify. So we'll go through a lot of those things. And then if it looks promising, then what we would do is set you up for an in-person screening visit, which is about a 2.5, 3 hour visit. We do an EKG, physical exam, blood work, and teach you a lot about the apps and things like that. So maybe those are next steps. So I would start with the QR code or the REDCap survey. I can also put my email in the chat, and you're welcome to email me as well.
Okay, thank you.
Yeah, thank you very much.
Thanks.
Anything else right now? Oops.
Thanks for explaining that.
Yeah. Stop sharing. Are you able to kick me off the share? Oh, there we go. I'll stop sharing now. I'll just put my email in the chat. But if it's okay with you, I'd love to stay on and allow your meeting to go on. I'm curious because it's just so nice to see a nice group of people like this getting together.
Maybe we'll keep the black market discussions to a minimum then. Just kidding.
Oh, I don't mind that. I'm all about off-label
Anjali's
stuff.
laid back.
I'm really bad. But I think you have to get creative, like I don't know.
Yeah.
Can I just ask a question of this group? I'm just curious about people's use of Afrezza insulin, and if that's something people use at all in this group, or the inhaled insulin. I'm just
So we're not going to have too many people here. I would say that's not to say more of a southern thing or other various places. We did have a Frezza person come in and chat, and we kind of had some interest. I tried it too myself, but a couple things came up at post study. There's a couple more lung cancer cases, and we kind of said, with IVs, you're already at risk, or someone portrayed this question too. You're already at risk for, heart, kidneys, feet, eyes, all these things. Are you willing to risk even the smallest amount for like another organ for something with little potential gain? Like we kind of talk about rage boluses, sometimes the faster way to get it done, down and stuff like that. But I think we kind of like, hey, put this on a pause. There's 3 extra lung cancer cases, and it's kind of like understanding it because it's study hours. It's really hard to like really understand how long these people were using it. So not to interject with anybody, but I also want to kind of also protect the group from going down something that just isn't going to yield as much.
Oh,
fruit
totally. No,
on
I
its
was just
plate.
curious about experience because I just hear a little bit more about like the shorter duration and minimizing hypoglycemia, and just in that world, I feel like I don't use it very often, and I'm just kind of curious if others have used it.
Yeah.
But anyway.
I know there's a couple loopers in this group, DIY loopers and stuff, and I know that some loopers have started to utilize it kind of in the regimen to get down those pesky highs, but I don't think our loopers are on right now. Has anybody tried a Frezza? I don't think there's anybody here that has.
Well, if you have any kind of lung condition like asthma, you can't use it.
Yeah, that's true. Are most of the people in the group, I imagine everybody's kind of on a sensor. That's kind of standard of care now. Yeah.
Mostly tandem users and a decent amount of Omnipod. There's been a little exodus. Our one and only Medtronic user, I think, is not here tonight.
Okay. Yeah.
But
well, it's nice there's more options these days. But
yep.
I just switched to 780G system from Tandem and a G6.
How's it
on
feel?
recommendations of my endocrinologist.
You're using a Dexcom with the 780?
No, I
Oh,
ended up using their G4, their Guardian 4.
okay, gotcha. Sorry.
And I switched to Tandem because the Guardian 1 was a POS, and it was not catching my lows as fast as I needed it to, and the Dexcom G4 was. So I switched to the 4, got rid of the Paradigm pump, or the Medtronic pump, and got another brand which was compatible with the Dexcom. They no longer make that brand, so then I went to a Tandem, and the Tandem made it, is compatible with the Dexcom G4, G5, G6, and made all those. And when I went to the G7, I heard nothing but problems. So rather than go for a G7 when my pump warranty ran out, I mentioned to my endocrinologist that I was going to keep this pump and keep using the G6 until hell froze over. And he said, well, we've got this suggestion here. You should use one of these. And apparently he has an in with somebody at Medtronic. And so I'm on the Medtronic pump. It's, shaking hands. And so that's where I'm at. So, yeah, you do have two now.
There you go.
So
How is
I'm
that going?
interested. Go ahead.
How has that been going for you? Is your sensor lasting the full 7 days? What do you think?
I use the other pumps to fine tune my insulin delivery in conjunction with the endocrinologist. I would do a test for 2 weeks or 3 weeks, and if that didn't work, I'd back off. I'd tell the endocrinologist what I did, and they would suggest a different method. So then I made those adjustments, and right now I've got control of the G4. It doesn't work any faster than the G1, but the pump seems to be more responsive. And so far, I think my last A1C was 6.7. And with the Tandem, I was down to 6.2. But I'm still working with this, and my endo wants me to be right around 7. He doesn't like it to be down to 6, and he doesn't like it to be up to 8. He's happy with 7. It's okay. Well, whatever you want, I'm happy wherever you're happy. And so it's working out so far. I'm still fine tuning it because it was a little bit of a challenge to relearn a different computer programming and how it reacted with my body. The insulin, on one of the other reasons that I got rid of the Tandem was their insets. For some reason, their insects leaked after 1.5, 2 days. Just consistently, I had 3 insets leaking out of every box of 10, and I got really tired of blowing off insulin all the time. So I never had a leak with the Medtronic, and so I switched back to that, and so far I haven't had any leaks. And I assume it's just because my body style. I have no idea. I mean, the Dexcom G4, G5, G6, that stuck to me for 10 days like glue. But the inset, 2.5 days gone. So other than that, I'm doing good.
Good to hear.
And I'd like to share the study because I am an erratic person. Sometimes I feel it coming on.
Yeah.
Before the pump goes off and tells me I'm at 60, dropping. Other times I don't feel it at all. I'm just tooling along, and all of a sudden you're at 60, and it's like, okay, well, 60 and 15 carbs, that's just not fast enough. Then I have to sit down and just wait for my blood glucose to catch up, and then I'm tired afterwards because it blah, 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 and so
Yeah.
it's just kind of a hassle. Of course, other people go, "You got type 1 diabetes? Oh, that must be terrible." I go, "Well, I don't know. I mean, it's better than having cancers." Well, maybe not, but it's everyone has their little thing that they drag around with them all the time. Their little ball and chain. It just varies from person to person.
Thanks for sharing. That's, it's so interesting. I mean, it's great that there's something for everybody, but I think it's, despite all this technology, you just realize like how much work you all do every single day. And I always admire like people I see in clinic every day because I just am amazed by all the steps they have to take. I mean, my life is busy without all those steps and interruptions after interruptions. I know how hard it is, and to do it well is just a lot of work. So appreciate you all.
What brought you into endocrinology, by the way, Anjali? Do you have any family members with it, or
Well,
what's your passion?
my dad's from India, and there's just my whole family has diabetes, and it's kind of a weird type of diabetes where they all went on insulin, but they're not type 1, you know.
Yeah.
But that wasn't really what got it. It was my physiology teacher in PA school. It was really amazing, and he was an endocrinologist, and I don't know. He just got me. I was just fascinated and I knew I wanted to work in endocrine. So I found a research job right out of graduation and they told me I wasn't qualified and everything. I'm like, no, I want this job. So I just kind of pursued it. And I've been working with Dr. Sequist since day one, and she's, the best mentor, she's just been great. So I've learned so much from her, and just taking a research path and also doing a clinic is just a nice complement to be able to build my clinical practice. So, and also it's nice working in research because you get to know people in a little bit different way, where you have a little more time to know them. So,
We want to know if we can make you an honorary member. Have you ever induced a low blood sugar?
oh, all the time.
Yeah, you have.
Well,
You've done a clamp or taken some Novolog,
oh yeah.
Humalog
Oh, you mean induced it on somebody else or on myself?
on yourself. That's why you would be an honorary member with that.
Oh, no, we'll have to try it. Actually, I did do it once. I allowed somebody to do a clamp. One of the endocrine fellows had to practice a clamp. It was actually Luke Benedict. You know him, Sarah.
Yeah.
But he did a clamp on me and lowered my glucose. So yes, I have experienced. I think he got me down to 53, and also I'll have to say I clamped my husband, and he ate like 10 granola bars, and he's like, I don't know how anybody can go low like this. And he thought I
Yeah.
was crazy for what we do.
How did you feel at that 53?
Oh, pretty awful. Like
You were
just
there.
feeling
Okay.
like my chest was pounding out of my body and just absolutely terrible. Like I felt like a bit of a panic attack, you know?
Yeah.
And I don't normally experience that. So it was just very uncomfortable. And you just wanted to eat the whole refrigerator, you know? And I'm sure, as you guys know, trying to control that is challenging when you're low, right? And with these new pumps, it's always like, oh, eat 5 grams of carb, that's plenty. And I'm sure that's challenging.
Yeah. Well, kudos to you for being brave enough to that. I've heard of one other endo, Farha Khan, I think induced a
Oh, yeah.
low and
Yeah.
stuff. And I was like, just the empathy it gives you. You can be like,
Yeah.
oh, diabetes is so logical. You just do this and do that. But when you have like that, you got to eat something or you're going to die, and
Yeah.
you just don't have the
It's a
brain cells to put
terrible.
it together, it gets
Yeah.
wild.
Yeah. Brian, did you have a comment?
Yeah, I was just curious. Didn't your dad teach at the U, electrical engineering?
Wrong Kumar. Kumar's like Smith in India, sadly.
Oh, okay. All right.
But no, my dad was at the University of Illinois in Chicago, not here,
Oh,
but yeah, that's where I
okay.
grew up. So,
All right.
no, there's a lot of us Kumars out there, I can tell you.
Okie doke.
No relation. Yeah, Carol?
So I belong to the dinosaur group of people who don't want to pump.
Yeah.
And with all your thousands of patients in all your years, if you were to figure out a percentage, if you can do it with percentage or numbers, I mean, what percentage of all the type 1s that you've ever heard of do you think still insist on only using shots?
Oh, I have a lot of them. I mean, I think not everybody wants to be connected with something. And, I mean, I think the number one piece is a sensor, right? Because knowledge is power. If you know where you are, you can do something about it. I think the hybrid closed loops are amazing for those who want them, but not everybody wants them. So I have quite a few patients who either do a combo approach or do the pump sometimes, or or they prefer the injections. I have a lot of people who use InPens where it logs their dosing. I don't know if anybody's ever used one of those, but basically, if I have somebody who's not on a pump, where for me, it's a lot easier as a clinician to help you to figure out what works well for you if I have something to look at, some data. I'm sure, Brad, you know this, right? And so some of the newer smart pens are really helpful for that. And again, I'm not promoting anything, but I'm just saying if something is automatically logging your doses, then we can work out, why are you going too low? Why are you, what's happening? So that's where I would say if somebody's not interested in a pump, I usually suggest looking into a smart pen.
Although you're supposed to put it, like if you have an Apple, if you're what am I trying to
Dexcom,
say?
you can note.
Yeah, you're supposed, every time I have a shot or every time I eat anything, I put it in my phone.
Yeah.
So
Well,
that's data.
that's data. Yeah, absolutely. It's a lot of work to put that data in there, but that's data.
Yeah.
But yeah, depending on how things are, but that's very helpful. So, to answer your question, I don't know about Brad in your practice, but I mean, I probably have 15 to 20% of my patients that don't want pumps, and they're maybe it's not that high, but I feel like it's changing now, and the costs are substantial too. How's your practice, Brad?
Yeah, I think that number gets lower and lower. There's some that are just like, I still want to do a vial and syringe. And you're like, okay,
Yeah.
And so, it depends working it in. I agree that CGM is just the biggest breakthrough. If you don't have CGM, it just feels like you're naked. You're like, am I 100 going low? Am I 100 stable? What am I? And that's tough to imagine how we did that for so long.
Yeah.
And Ellen could probably tell us more. I think she's our chief senior with diabetes. I think it's 67 years. Is that right, Ellen? Yeah, we
That's
have one
amazing.
other 67 years living with it, and it's just great to see these people with little to
Yeah.
no complications paving the way too.
Yeah.
But I gradually get them into it. We talk about half unit dosing, something that can take some work off their plate because you guys have worked long enough decades. If you can make something do it for you and make it so you're not pressing the gas when it's pressing the brakes and all that, I think it can benefit a lot of people. But if they're in that mixture, I just kind of say, hey, here's something, here's what it can do. And they have a lot of ideas. They've heard stories that this pump try to kill somebody or did something else. It's usually not the case. It's usually some miscommunication, some misunderstanding. These pumps they make super conservative, but I don't
Yeah,
know.
but I think
That's tough. 20% I would say, around there too.
and I think it's important to honor that in people that, some people are just not interested. And I feel like I've seen some patients who have felt like their endo has pushed them into something that they don't want. And that's not a good feeling. Like we're independent adults and we should be able to make those decisions. So yeah, no, Carol, you're not alone.